public hospital, a university hospital. I worked there since 2001, and my field is headache diagnosis and treatment. Can I start?
Yeah, India, I have a small request. Can you ask Celsia to also to give one small talk?
Sorry?
Yeah, Selina, our friend Selina.
Is there Selina here?
From Siena University.
Is
can you request?
Is Selina here online?
Yeah. Our old friend.
Okay.
Our old friend.
Okay.
So you just
okay.
need to have to give one talk on Monday or tomorrow. Or today.
I cannot listen to you very well. So I can understand each word. Yeah, maybe if you want, you can chat. Maybe I can read you.
No, 1 minute. You request Dr. Selina to give one talk tomorrow or today.
Oh.
Can you hear me?
Can you repeat, please?
Can you request Dr. Selina Celsia from Siena University? I don't know how to name.
Of Siena, yes.
Yeah. So you request her that I have requested her to give one talk from Italy.
Oh, tomorrow I'm not able, sorry, tomorrow I'm not here. I'm not able to talk again.
No, not you. You just request her.
Okay. Is Selina going? Okay. So maybe we could chat later. Okay.
Yeah.
Which topics?
Talk. All the best. Good morning. Any topic, whatever she likes.
Can I start?
You please start your topic. Yes, you can start. All the best. Good morning.
Thank you very much.
Thank you so much.
Good morning to everyone. I would like to share slides. Today we talk about headache management. We talk about headache syndromes because they affect really a lot of people. It's supposed to be around 40% of the population. And what's important is that they can start from age of 5 and remain for age of 18. It means all life long. It means they can be very disabling for the life itself. People cannot work with headache syndromes. People cannot do anything. When we visit a patient for the first time, we always have to ask ourselves, does the patient has a primary headache disorder or a secondary headache disorder? This is the first question, but it's really, really important. Primary headache disorders are disorders where headache is the disorder itself, while secondary headache disorder, pain, headache, is just underlying a secondary disease. So it's really, really important to know which kind of a headache you are seeing. We use the international classification of headache disorders. It's made by International Headache Society. The first edition was in 1988. Now we have the third edition released in 2016, and the fourth edition is in progress. It means that it's headache syndromes are changing, and diagnoses are focusing all and changing all the time. It's very important to use international classification, so a clinician from Italy can make the same diagnosis than a clinician from USA or another European clinician. International Headache Society, it's a very old society, and it's made by researchers and clinicians from all the world, all the Western world, mostly European and USA people. According to this classification, we have primary headaches, secondary headaches, and then we have a third part called cranial neuralgias or other facial pain. And this is such a waste basket and with strange patterns of pain. Primary headaches are the group of migraine, tension type headache, and trigeminal autonomic cephalalgias, such as cluster headache. And we have other primary headache disorders, such as chronic migraine. Secondary headaches, we have one chapter dedicated to headache attributed to trauma or injury to the head. These are very common in Western countries. And headache attributed to cranial cervical vascular disorder, such as a vascular malformation and central venous thrombosis. Then chapter 6 is dedicated to chapter 7, sorry, to non-vascular intracranial disorder like seizure, neoplasia, or for example, increase of cerebrospinal liquid. So very, very different disease. Chapter 8 is also it's very common in Western countries because our headache secondary to substances, and they are headache secondary to overuse of drugs. And for drugs, I mean analgesics, a simple analgesics drug or mixed drug or opioids drug. This is a big, serious, big problem in Western country, most in USA and less in Europe, but in Europe is still starting. Number 5 are headaches secondary to infections such as meningitis, so they are dangerous headaches. And number 10, they related to homeostasis disorder, mostly in patients with, for example, a chronic renal failure, in a patient with dialysis, or in patients with pathologies of thyroid glands. So often hormonal disorders. And then we have still in part 2, we have headache secondary to all disease of eyes, ears, nose. It means here we have glaucoma, can spread headaches, infection of ears, nose, sinuses, infections of teeth and or mouth. And then we have disorders of the neck, and so we have cervicogenic headaches, and in people with, for example, discopathy, cervical discopathy, with pain of the neck and then headache in the head. Then we have part 3, we have facial pains, strange facial pains, and other headaches that are not easy. They do not stay inside part 2 or part 1. Every time, especially if we are in an emergency room or a first aid room, but also in clinic, first time we see a patient, we have to check for red flags. Red flags means dangerous headache, dangerous for life of the patients, because maybe underlying severe disease. These red flags can be taken from patient history, such as thunderclap headache, or head trauma or progressive headache. Is a red flag headache onset at years of 50 or more than 50. Usually from 50, we have not anymore primary headaches, and they are almost or secondary headaches. Other red flags can be taken by physical examination. Every time we see a patient, we need to perform a physical and a neurological examination. Then we can see signs. We can see neurological signs, or we can see vital signs. So we can catch red flags. That's very, very, very important. If we find red flags, of course, we have to perform neuroimaging very quickly. Okay, between primary headaches, we have the group of migraine, and migraine with aura, migraine without aura, chronic migraine. And today, in my talk, I focus on migraine disease. And that's because migraine, according to the World Health Organization studies, is the second most common neurological disease in all the world. It's a prevalent headache disorder. Migraine can be without aura, and then you can perform a diagnosis of migraine headache when your patient have at least 5 attacks of headache, 5 attacks in 6 months. So each attack must be lasting from 4 to 72 hours. Headache must onset must have unilateral location at the onset, and then can go to the other side. Pain usually is from moderate to severe intensity, and it's a pulsating quality. That's very, very important. And pain is going to get worse if the patient try to keep on going with a routine with physical activity. But migraine attack is not only pain; it's pain and nausea, or nausea with vomiting, and photophobia, phonophobia, and can be also cognitive impairment. In this picture, there is a migraine attack. You see the lady has a moderate severe pain, pulsating. It's a throbbing headache. And usually patients try to put their hand where they feel pain. What's important that usually they have cognitive signs. They have confusion. That means they are not going. They are not able to think, and they can have phonophobia, photophobia, and loss of concentration, and need to rest in a dark room in silence for at least 6-8 hours. Why the difference between migraine and without aura and migraine with aura is that in 1/3 of patients or migrainous patients, people experience aura. Aura is a transient focal neurological symptom, fully reversible, and it mostly it's a visual symptom. It can be expressed as phospheny lights, colorful lights, or can be fortification spectra. It means aura, a neurological aura in migraine might spread over 5 minutes, so it's very slow, and it lasts for 1 hour, no more than 1 hour. This is very important because you have to make a different diagnosis with transient ischemia attack. And you can do it because here neurological symptoms spread very, very slow. 90% of patients have a visual aura. Then about 30% of patients have a sensitive aura. It means they can have dysesthesia or paresthesia in the arms. Usually these symptoms start from fingers and then go up to the arm, and then they can have speech or speech neurological speech alteration. They can have aphasia, but it must last no more than 1 hour. After all the neurological symptoms come up, the migraine attack. This slide show neurological aura. So you can see on the left you have visual aura. You see it's spreading very, very, very slow, and then become bigger, and then become very, very small again. And in the other picture you can see fortification spectra. It's colored. You can see the rainbow colors, and it moves. It takes about 40-45 minutes. When we suspect migraine, we can suspect migraine headache when we have a recurrent headache from moderate to severe intensity. It means that patients usually since 12, 13, every month or every week, they have 1, 2, 3 headache attack, lasting from 4 hours to 3 days. These attacks are always have the same pattern. This is very, very important. Often they have a family history of migraine, and when you see this patient, it's very important you can apply the diagnostic criteria. If you cannot apply diagnostic criteria because they do not fit, so you cannot perform a diagnosis of migraine. Then you have always to make a physical and a neurological evaluation to exclude other disease that can simulate migraine. When you perform a diagnosis of migraine, you have to decide the management of the disease. Migraine, it's a chronic disease. It means it will never end. Also because there is a genetic basis. It depends from the frequency of the attack. You can choose for an acute treatment, so treatment during pain, or you can choose for a preventive treatment, a treatment that lasts for 3-4 months, even when pain is not there. And this is pharmacological treatment. Then you can choose for non-pharmacological treatment, or you can do both, and this is integrative medicine. In Europe, World Health Organization wants that European doctors try to make integrative medicine. There are line guides about that. This is the consensus statement by European Headache Federation. It's a 10-step approach for diagnosis and management of migraine. When we have a patient with maybe a low frequency migraine, maybe once a month, we can decide for only an acute treatment. And we have first-line medication, non-specific medication. So we can use analgesics. Ibuprofen is the first one we use in Europe. Or if patient cannot take it, we can use paracetamol, acetaminophen. First-line medication is a medication that you can take you can have from all kind of doctors, medical physicians, and so the first step medication. It's very important to check for contraindication for this kind of medication, hepatic disease, gastrointestinal bleeding. So if present, you cannot take these drugs. After first-line medication, if patient do not have relief with the medication, you can go to second-line medication, and then you can use specific drugs. So we have triptans. We are talking about oral medication. And in Italy, we have naratriptan. It's in USA, naratriptan. And triptans are agonists of serotoninergic receptors subtypes 1B and 1D. There are important contraindications that are cardiovascular or cerebrovascular disease, or hypertension, or hemiplegic migraine, or migraine with brainstem aura. In case of this disease, you cannot use triptans because you can have a serious event adverse. If triptans alone are not enough, you can add an analgesic drug, or you can add also you can add antiemetics such as domperidone or metoclopramide. Then we have a third-line medication that is usually prescribed from headache centers. Then you have new drugs. Daitens Japans. They are we use them since 2018-19. Daitens are they are specific drugs, are agonists of serotonin receptor subtypes F. Subtype F receptors are only in neurovascular are present only in neurovascular termination. Then we have Japan's. Japan's are really new released, and they are antagonists of receptors of CGRP neuropeptide, calcitonin gene released peptide is a neuropeptide involved during migraine attack. And they are new drugs. They have a lot of drug-drug interaction, so must be very careful when you prescribe them. Of course, you can add medication for nausea and vomiting. Mostly, they are supposting or liquid. Preventive treatment. You have to think for a preventive treatment when your patient have, for example, one attack of migraine a week. And then, for example, because cannot take any acute drug medication. Hello? Oh, okay. So what we do? Okay, okay. Where did I connect? What the last thing you heard? Yeah. Okay, thank you. Yeah, okay. Hello?
Dr. Alexandra, can you hear me? Dr. Alexandra, can you hear me? इसका voice दो. Alexandra, can you hear me? Alexandra, can you hear me? Can you hear me? Alexandra, can you hear me? We are not able to hear you.
Do you hear me? Do you
Yeah,
hear
you
me?
can start. The slide is 20
Okay.
number 1. 21 number slide.
Okay, thank you very
21
much.
number slide.
Yes,
21.
just a second.
Yeah, continue
Yeah.
with 21. Sorry for
Should
the
be this
interruption.
one, is
Continue
it?
with 21. Yeah, continue with 21 number.
Yes.
Continue with 21 number.
Okay. This one? No, it's not. Maybe this one. Can you hear me?
Yeah.
Yeah.
Yeah,
Okay.
right.
So with preventive treatment, we have a first line medication, and we have beta blockers. Then we beta blockers. We have to check for asthma or cardiac failure and atrioventricular block because they can be dangerous. And then we have topiramate. Topiramate is an anticonvulsant, and you have to check for nephrolithias and pregnancy. And you have to check also for glaucoma. If patients have this kind of disease, you cannot prescribe topiramate. You can also use candesartan. Candesartan is angiotensin second receptor blocker. They are cardiovascular drugs. In Italy, usually we use a different dosage. So, for example, we use a lot propranolol, and for our patient, 40, 80 milligrams oral once a day, it's enough. Then you have a second line medication, flunarizine. It's a calcium antagonist. It's a very good drug, but you have to check for Parkinsonism because it blocks the dopamine receptors. And amitriptyline, it's a tricyclic antidepressant. It's a very old drug. It's a drug. We have this drug since 1960 years, but it's very, very useful, especially if your patient has a comorbidity with mood pathologies such as depression depression. And you can also use sodium valproate and other anticonvulsant, but you have to check liver disease, thrombocytopenia, and of course pancreatic disease. Then we have third line medication. They are they released in about 5 years ago, and they are monoclonal antibodies. All the therapies in Europe and USA now are focused on monoclonal antibodies, and are antibodies against CCRP receptors or the CCRP neuropeptide. We also have botulinum toxin A, also for chronic migraine. What is important is all these drugs need to be followed in when you prescribe these drugs. So you have to check for contraindication, and you have to check for drug interaction. And sometimes you have to check with a blood sample for thrombocytopenia. Then you can choose a drug in base of your patient. For example, if you have a patient with hypertension and migraine, then you can use a beta blocker. Or if you have a patient with a seizures or with a bipolar disease, you can use an anticonvulsant that help you to stabilize your patient. Usually, you use this drug one drug at a time, just one monotherapy. It's better do not add too much drugs because of drug interaction. These are the really new treatments of migraine. Atto Japan, Zave Japan are very, very new. Zave Japan was released in USA in 2023. It's a nasal spray, and it's very useful for migraine attacks, mostly for acute treatment. And now we have from 2020, eptinezumab. It's a blocker, a CGRP receptor blockers. And what's different? It's a preventive, also always a preventive monoclonal antibodies for migraine, but you have to give it intravenously. So it's not oral. It's very important because it lasts for 3 months. What is very, very important? It's to give a look to special people. When you prescribe drugs, you have to look to older people. Older people in this age, they can have a lot of side effects from drugs. So you have to visit, to follow your patient every 3 months, just to see if the patient has drugs side effects. A special population include pregnant women or breastfeeding women. Then you can use for sure acetaminophen for acute treatment because it's safe for teratogenic effects. While you have to avoid preventive treatment because they can be teratogenic, and it's very important. In women, for example, in my clinic, I use acupuncture treatment in pregnant women and breastfeeding women. Just to remind a few things, it's very important to when you perform a diagnosis and you prescribe drugs, you need to visit again your patient and ask him to take an headache calendars to understand if drugs you prescribed are giving some effects or not. If you see your patient is getting worse with therapy, with therapies you prescribe, then you have to check again for diagnosis, and maybe you perform imaging, neuroimaging, just to check and to exclude a secondary disease. There we have at last no pharmacological treatment, and no pharmacological therapists. They begin with avoid triggers of migraine. It means to sleep well, to eat well, do not take too much alcohol, avoid lights, and avoid very loud sounds, and have a good sleep. These are most common trigger factors for migraine. Then I just told you before, acupuncture. We have guidelines, international guidelines, European guidelines, and Italian guidelines that allow acupuncture as a good therapy for migraine. Or you can choose for neuromodulating devices. Really, in Italy, they are not so common. I'm looking for the last. Okay, no, this one. And in Italy, we only have Cefali. We have no gamma core because the trial was not good. And in USA, they have gamma core, Nerivio, Relivion, And in Italy, we are starting with single pulse transcranial magnetic stimulation. But at the moment, in Italy, the most common therapy is pharmacological therapy. This was my last slide. So I thank you for your attention and ask you sorry if I made mistakes with English and with pronunciation. Thank you so much.
Thank you. Thank you so much.
Do you have any questions?
Dr. Alexander, can you hear me now? I'm Dr. Sastry, India. Can you hear me?
Hello, yeah?
Yeah, it was a very beautiful talk, lot of insights. I've learned lot of things about headache. I always
Thank
thought
you.
headache is a headache, but after reading your slide, I realized headache is a beautiful headache.
Headache is a big chapter of medicine. You have more around 200 diagnoses of a headache. It's just not one disease.
Ah, for the first time, it is wonderful to hear that we have 200 diagnosed and 300 types of treatment.
Thank you so much.
We are very thankful to you. Please request Dr. Celsina from our sister from the university to take one more class on whichever topic she likes.
Thank you. Thank you so much.
You please request
If
her. You please request her, Selina.
Sorry?
Dr. Selina from Siena University.
Want to ask me something, Dr. Selina?
To give her a talk like you. She can give a talk whichever she likes.
Okay. She can call me anytime.
Can you can you give a call to Dr. Selina?
Sorry, I can't hear you.
Can you give a call to Dr. Selina?
Can I give?
A call to Dr. Selina?
Can you please type? Because
Okay,
I do not hear anymore. It's a very
bad internet connection. So anyway, I thank you. Thank you so much for everything. It's a beautiful hearing you. It's a beautiful relation we have established with Italy and India. We believe that this relation will go in a long way. We will mutually participate in our research. We'll also teach you about NTCM, and Dr. Farah from Germany will give a live demonstration on NTCM, live navigation transmagnetic stimulation.
okay. Okay, that's very nice. Because
So
in
she will
Italy,
be giving. In Italy, it is for the first time in India, in the world. NTCM is coming up.
Okay. So thank you for everything, and
Thank you so much
have
for
a
everything.
nice workshop today.
Thank you so much. God bless you. And I pray for your healthy being and our healthy relationship for the betterment of the sentient human being. Thank you. Buddha bless you. May in the name of the Father, Son, and the Holy Ghost, you be blessed, and may you be happy year after, thereafter, and so after. Thank you so much.
Thank you so much.
Thank you. Thank you so
The
much.
same
Thank
to
you.
you. Bye-bye.
Thank you.
you.
Bye. Bye. Oh. Now you see, it's a very beautiful case we are presenting. लाइव मैं तो लाइव कर रहा हूँ